For Chorus Collective and NYU Stern School of Business, Berkeley Center for Entrepreneurship, I'm Leon Lee.
And I'm Antonio Di Meglio. This is Capital Calling, where founders step into the spotlight to face real investors, real feedback, and a real opportunity for investment.
Now, let's meet our founder.
Joining the call today is Lokesh Sharma of CaroRhythm, who is reimagining how we monitor vascular health. His device provides continuous, non-invasive insight into the carotid artery, helping stroke survivors stay ahead before warning signs become emergencies.
Will he answer the call? We'll find out.
But first, let's meet the investors.
Lokesh, capital is calling. Do you have what it takes to keep the rhythm alive?
Hi, I'm Lokesh Sharma. I'm co-founder of CaroRhythm.
As you know, I'm Rene Bastone. I'm a venture partner at Covenant Venture Capital. We invest in early stage companies, deep tech companies generally speaking. I lean towards digital health companies, healthcare, and biotech companies.
My name is Sabria. I'm a partner at SOSV. At SOSV, we like to be among some of the first, if not the first check into companies. Our investment thesis is human and planetary health, and we really are looking for founders who are using science and engineering to solve some of our most pressing problems.
It's great to meet. Looking forward to hearing more. My name is Doug Hayes. I'm founder of Gento Health and also a strategic investor looking for early stage health tech companies that can support patients, caregivers, and families. So great to meet.
Great to meet all of you. And let me start before explaining what CaroRhythm is. Let me start by asking you a question. Do anyone of you know who's had a stroke?
Yes. Absolutely.
Exactly. Stroke is a very pressing challenge, and it's very sad to know that every 40 seconds someone has a stroke in the US. That's 2 strokes within the timeline of which speaking. But the problem is not in the hospital. It's when the patient comes outside the hospital, and that challenge has yet not been solved. So the biggest problem is that most of the patients, 1 out of 4 stroke survivors, will have a recurrent stroke, and they will not be able to detect it. Now imagine if the first early warning sign is not a symptom but a notification on your phone. At CaroRhythm, that's exactly what we're trying to solve. We're building CaroSense, a medical device that detects early stroke warning signs such as last known value and other symptoms and helps patients to get to the hospital early. We have had multiple traction with different healthcare institutions, and we've also conducted a preclinical study on healthy subjects at NYU Langone. We've also done, we're also developing a second generation prototype, and our next stage is to do a clinical study on stroke survivors. We've raised $150,000 with non-dilutive grants and have had partners engage with us such as NYU Langone, Wyckoff Medical, California Rehab Institute, and Jacob Institute in Buffalo. We're looking to raise $500,000 for the next phase to support clinical and technology development, and we would love to have you on this journey because no stroke survivor should always wonder, am I safe? Thank you. I do have some demos for you. It does look very chunky. This was the second generation prototype we developed. As I can go here, this is exactly what CaroSense looks like. This is a mock-up of an early generation prototype. Let me just pass this around. So that's generation 2, and that's the new mock-up that we're developing with generation 3. It sits over the carotid artery and sees changes within the blood flow. And what it essentially does, it helps the patient to know the last known well. Patients will wear this for 2 weeks continuously, and within those 2 weeks, we can create a stroke prediction risk. Now, there is a patient-centric app, an app that lets you know that you are at risk of stroke and you should reach out to your physician. But the physician also has telemetry, and they can see real-time statistics of the patient, and also it integrates within the EHR and allows the individual to communicate and let the physician know that the patient be at risk. We are obviously, we have a great team. Nisha, my co-founder and CEO of the company, has vast knowledge of experience in biomedical engineering and developing medical devices. We have spun out from the NYU Clinical Biophotonics Lab, where we develop vascular devices, and we also have other business mentors.
Can you talk a little bit more about the preclinical study that you've run, and how many patients, but also did you see any differences between men and women who, maybe the question is, will you be able to see differences between men and women who have strokes? Are there differences? And how will your device account for that?
So the preclinical study that we did was on healthy subjects. And so our focus was to essentially see if our early first generation prototype was able to detect changes within the blood flow. What we did is we use a patch over the radial artery and over the carotid artery on both sides and try to determine if we can catch changes in blood flow based on different breathing exercises. We did see that there was a clear similarity between what we were seeing with the standard in radial artery to carotid artery. And so that was the initial study. Since then, we have done internal testing within the lab and with people inside the lab to understand if we can see plaque determination. And so there are factors that differentiate us from our competitors out there in the market, is that our imaging tool is based on diffuse optical tomography, which is able to capture composition of plaque and characteristics of plaque, which is a very key problem in atherosclerosis.
And so you said 1 in 4 survivors will have a stroke after they leave the hospital. And so how often does it happen? Is it, because you said you only did it for 2 weeks. So is it 30 days? Is it 2 weeks? And is the idea that when someone does leave the hospital, how long would they need to wear it?
Oh, that's a fantastic question. So the basic workflow that we are thinking is, first of all, 1 in 4 stroke survivors are at highest risk of having stroke in the first month. That's exactly why we're targeting the 2 weeks timeline. Because if we can create a vascular health profile for them personalized to their metabolism, we can predict the stroke risk, but we can also report to their physician if the medications are working and they are progressing in a negative way or they're improving in terms of the recovery. And that's our main target. The way we see it is that in most cases, once the patient is discharged from the hospital, they will wear this device for 2 weeks. Then they will put it inside a box, ship it to us. We will re-sanitize it, and it can then be used for another patient. But we'll also create a specific document that will be then sent to their physician and to them, and will help them know in what is the next mode of intervention.
Really impressive. I have 100 questions about the technology and what you're actually doing, but I'm going to take your word for it. And the applications and the unlock could be so exciting. I have some more fundamental or high-level questions, however you look at it. But are you a stroke tool or are you a imaging platform?
We are an imaging platform.
With stroke as the first modality?
Yes, exactly.
Do you have a second thought out?
Yes, so that's actually a fabulous question. The way we like to see it is stroke is one of the diseases that have no outpatient monitoring devices out there in the market. And that's very bad because you use something for AFib, which is the Zio patch, to basically compensate for being at risk of stroke, while AFib only accumulates for 35% of actual stroke cases. So we do see that as the first case. Now, after that, we can detect anomalies that could be because of hypertension, COPD, and other disorders, just because the carotid artery on both sides is the conduit to blood flow to the brain. And a lot of differences within oxygen saturation, within blood flow, and different other flow parameters can help us determine that.
But just to finish that train of thought, you could imagine down the line enabling providers to take risk on a stroke, which is kind of wild to think about. If we could have confidence that this device would give us an early signal. We didn't talk about what happens when there is a signal too much, but I'm sure you've thought that through. And then another question I had is that, is this a data set? And I know that's cliche, but doesn't it seem like, are you creating a new data set?
We are creating our own data.
And talk a little bit about that.
Yes, so our goal with the clinical study that I mentioned is to create data sets on stroke survivors, to monitor them for 2 weeks and see the comparison with healthy subjects and set a baseline. After that baseline, anyone who's outside the baseline, maybe because of high diabetes, hypertension, or just has plaque or any composition occurring in the carotid artery, we can flag that as you should maybe go and talk to your physician and see what is next. Most of these cases where there's less than 70% occlusion, which means your carotid artery still has some flow to the brain, they will not operate. But that does not mean that they are not at risk of stroke. They just are not operating at that moment because insurance might not cover it. So those patients are at high risk, and they need tools like this in which they can be in the comfort of their home and still be monitored and know that they are safe.
Well, and actually, something that Doug did say, which was going to be my question, is so, and maybe you touched on it just here, which is what does happen when a signal gets generated? Is there an app that the doctor has? Is it more of a, is there a spectrum of, okay, it's okay if you stay at home for a little bit, or it's like, no, you need to get yourself to the hospital immediately? But then, and I wrote it down here, maybe because you said it, or maybe because I was like, but what about false positives? And how do you kind of mitigate for that? Because you also don't want people coming into the hospital if they don't need to. Exactly.
So I think the more questions to it. So I'm going to answer the first one, which is yes, there are, like I mentioned before, there's a physician-centric side of the app, and then there's a patient-centric side in which caretakers and patients can both track their health status, but they can also actively see if they are improving or they need to go to the physician. Now, to avoid regulatory hurdles, we are not a diagnosis tool. We help physicians in diagnosis. And so in that way, we're just notifying the patients. It's still on them to adhere to their medical physicians and really follow up with them. The challenge being is that in many cases, they obviously could be false positives, and that's exactly why the clinical study that we are planning to do sets a baseline precedent in which we, from our customer discovery, we've understood that physicians want patients to come in and check up with them just because a 2-week monitoring period allows them to gather enough data to know that this patient is constantly not improving even after medications, and this patient is improving only in certain cases in which the doses can then be improved and they don't have to come in. What this basically does is there's an after effect of how physicians can then schedule their patients based on priority and not just hope that after the 1 month I see them, they are improving.
Does it add a more complex layer to say, okay, it's going to be this device that someone has to send back to their hospital or to their doctor? Like, is there a way, or is there a thought that you could either continue to miniaturize it or make it more like a sticker that they can just then dispose of? Or I'm not advocating for creating more waste, frankly, but again, just thinking about how to make this maybe a bit easier for the patient.
Right. So we are an imaging platform that does mean that these electronics are a bit more expensive. They also require batteries, so making it thinner sure would be ideal, but a stick-on would just create more waste. And also, in terms, this tool is very versatile and it can be reused again. So our idea is to have a rental model at the back end where this device comes back to us. And this is very similar to other wearables out there in the market because most of them, they do send it back, get sanitized, and they can reuse again within the same healthcare facility.
And does this replace anything inpatient? Sorry, Renee.
No, it does not. It's an additive tool to the current workflow, but there is no outpatient tools out there. So.
No, but what I was thinking is like monitoring inpatient. After a patient has a stroke and they're in the hospital, would it be effective to put one of these on them?
At this point, we do feel that most hospital institutes, they have a standard workflow that they will not change from. We do not want to be an alternate to CTA or MRI because those are essentially better imaging tools that still require to be done on patients that are high risk. We are just the ones that can notify them that they might be at risk, and so they might need to go in earlier than what they would think.
But so going back to two things. Number one is we haven't really talked about the what's happening with the data, the algorithms that you guys are using to analyze this. Can you tell us a little bit more about that? And then I have a second question about who's actually paying and how they're paying, right?
Perfect. So the algorithm that we use is developed by our researchers. It's something that we've been using. It's proprietary to our lab as well. And we developed this technology at NYU, and CaroRhythm has exclusive license to use that technology. What we try to do is basically identify patterns that are perturbations from the baseline. So creating our own data and setting a baseline is important. One of the reasons that we are trying to do this study is also to get that data and then train the algorithm to better predict and avoid false positives. We do see this as a Medicare reimbursable tool. We are a Class 2 medical device, and we have been talking with multiple payers such as Clover Health and other Medicare Advantage plan providers. We think this tool can help also with value-based care payers because we can provide the benefit of primary prevention by helping them reduce the risk of their patient population.
I mean, that was the next question is, have you looked at things like, readmit, reducing readmissions and all of these types of things? So have you started to gather that data yet or not yet?
Yes, we have. I think there should be another slide. Right, so we have had some calculations done, and we think that our tool can help not just the patients, but also in terms of providers and payers, it reduces length of stay, so that's $20,000 per patient. And with payers, it helps in readmission because we can help them not go to the hospital multiple times and get them at the right time and get the right care they need at that moment. We also have identified different CPT codes that we can fit along, although a longer arch would be, as a de novo device, we do see that we would require our own CPT codes in future.
In the future, will this device allow other researchers to find interventions that you're not thinking about right now in applications?
The technology itself has been broadly used. Diffuse optical tomography in general. The only innovation that we are getting in is I shouldn't really put it lightly, but we are miniaturizing it to make it wearable. And there are wearable DOTs out there for brain imaging, but there have been none for carotid artery. And so vascular monitoring could be a next advent, and for different diseases such as peripheral artery disease for lower extremities, that could be one of the aspects as well, which we do already do research in our lab.
Depth, can you image?
We can go 2 to 3 inch deep.
Right, so fairly big applications, yeah. Lokesh, great to see you again. Great to see the progress that you've made. We're going to deliberate for a little bit, and we'll see you in just a few minutes.
Thank you so much, everyone.
All right, judges, it is now time for the judges' debrief portion of the show. What did you think about the pitch?
I thought it was really polished. I think he came across very knowledgeable about the space. I think he kind of pulled us in quite quickly with that, do we know anyone who's had a stroke? I thought it was quite clear as to what he had and what the next steps were.
Yeah, I think they're gonna have such a strong foundation. I mean, what an exciting thought to have a new imaging platform. And I'm really curious downstream, if you think about it like a platform, what are some of the unlocks and the applications they're not even thinking about yet? That's kind of the direction I was going, is maybe you're not a stroke company. Maybe that's the first module, but the way you're thinking, the way you're attracting capital and the story that you're telling, maybe that's a different story.
Yeah.
Especially since I think, wearables are having a moment, as they say.
Clinically valid.
Yeah, clinically valid.
Yes.
And they've got the chops to do that validation. Right. And you heard the platform, there are going to be a lot of applications, right? So it's 3 inches. You can image 3 inches down. There's a lot of cardiovascular, neurovascular applications there.
So I guess I have a question then, both for you, Renee, and for Doug then. If we're thinking about these longer term applications, to what extent should a founder have those applications be a part of their pitch right now? Because I could see there being a potential issue of maybe it getting confusing if the long-term applications are a bit too far-fetched.
You're right. You can boil the ocean, right? And the last thing you want is for a founder to be going after 20 indications when they still need their first $500,000 in funding. That's not what they're doing, though. They're focusing in on one indication. It's a really important indication. It's one that has a real need, and I think they're aware that there are other indications. They're not talking about them because A, probably they haven't figured them all out yet, and B, I think it dilutes what they're trying to do. So I think it's the right approach.
Agreed. I'm glad that he wasn't talking about that as much. I was pushing him a little bit from as a long-term investment perspective of what the upside could really be here. But your question's a good one. I would encourage someone to focus on the next 18 months, being able to tell a story of how you're going to get to meaningful milestones within that period. And a lot of times that means focusing on a certain indication. But I think if we had a little bit more time with him, maybe he would talk a little bit about broader applications downstream. But he's so early that focus is way more important than vision. and execution is way more important than strategy.
And so, Sabria, SOSV aims to be the first check in a lot of these types of companies. To what extent do you see the companies that you all end up accepting into your programs having this issue figured out of balancing the long term with the short term?
Yeah, I mean, I think I'll just actually echo exactly what Doug said. I mean, and Renee as well. I mean, I think we want founders to have big visions, right? But we also need to see a plan to get there. And milestones that matter, right? I think it can be great. I know, there's the bigger discussion on, platforms versus single assets. And, we appreciate looking at platforms, but platforms still need to be proven out by showing you can do one thing well. And so, yeah, I agree that, Doug was asking him about potential other indications, but he seems quite focused on the stroke go to market, and I think that's good because you want to have focus, right, to show that you can do that thing. But then it's always, here's what is possible, and here's how we are going to do those things. So I think for a lot of our companies, again, even at the earliest stages, we want them to, dream big, but be really laser focused on being able to de-risk their technology, show that there's a market for that, and then think about, kind of how to grow to be, $1 billion business. I will say one thing that I appreciated too about what he has is how far he has been able to get on grants. I mean, the fact that he already has his preclinical study done with healthy patients, already kind of knows exactly what he needs to use this $500K raise for. It doesn't feel overly ambitious, right? It feels achievable. And I think that's kind of exactly what we want to see for companies at this stage.
He's got 2 generations of a hardware device.
Yes, that too. Yeah, that's the other. Yeah. Yeah,
Right.
He already knows, kind of what the, de novo pathway looks like. I think, again, there's always going, especially in medical devices, there's going to be hiccups, there's going to be hurdles, but knowing what the path looks like, now is so critical.
The other thing I like, speaking of sorry, Doug, speaking of the path, is they're also thinking about that in a clever way, right? They're trying to get breakthrough. Designation, which is very important. I mean, for us to look at a company like that makes a huge difference in de-risking the company.
I know I focus mostly on the investment potential, but the fact is this is a huge issue. And it is horrifying to discharge a patient and know that there's a high percentage that they're going to have a second stroke within 30 days. And our chair of neurology has brought this up. We've heard this from the clinical community. So anybody who is really focused on this, I think, can make a great impact with lives as well as on the business side.
All right. Thank you, judges, for your feedback on Lokesh and CaroRhythm. Now sending it to Leon, who is currently on hold with Lokesh.
Welcome to the on-call room. My name is Leon. I'm here with Lokesh. Lokesh, how did you think you did on the pitch?
Oh, that's a very tough question to ask. I feel I did okay. All the judges had great question, and some of the most intriguing questions as well that most people can ask. Really, really came out with this with an open eye.
I'm curious, and for your company, where's the stage right now? Is it clinicals, preclinicals? What is the timeline for someone that's not technically in this field?
Right. So we are pretty early stage. We have done a preclinical study. Our next target is to do a clinical study. Although as a medical device, that's a non-invasive wearable medical device, so we do not require surgery. We do not require a lot of the phase 1, phase 2 clinical studies that are generally required by FDA. It is just on us to prove that without a doubt our devices are not significant risk. So for our class within the FDA, we think we are at that stage where we are really looking forward to kind of developing our next prototype, working with our hospital partners to get this out there, test it on actual patients and see the results and see if we can start making a big change.
Okay. And Lokesh, you have the technicals, you during your pitch, you pitched your technicals, but we're curious about the human aspect of what motivated you to start this.
We've talked about this. Me and my co-founder, both Nisha, we've lost our grandparents to stroke. I sadly, when I first came to New York about 3 years ago, my grandmom was walking in the park, collapsed, her left side of the body was paralyzed, and we didn't realize there was symptom of stroke, and it was already too late. Nisha's grandparent, on the other hand, did survive their first stroke, but eventually the symptoms just gave in. So this kind of makes it pushes us to really see exactly what the challenges are. It's very interesting that stroke has many reasons that it can be caused, but stroke has not been treated as it should be. We have different medications that we do, but we don't have any medical device out there with Fitbit, with Apple Watch, all of these things, but we still don't have devices out there that someone can take home and monitor themselves for stroke. And so when we started looking into this, we really realized the problem lied there. It's not anything within the hospital. It's the fact that you get to the hospital late, and that needs to change. And we are really excited to change that.
I'm also really excited to follow because personally, I have family that has suffered in stroke, so it's very close to my heart. For you and for CaroRhythm, what is the long-term goal, maybe in 5-10 years down the line?
Our goal is to improve stroke care beyond the hospital. We don't want patients to be always worrying about the fact that they will have a recurrent stroke. We don't want patients to think, are they safe or not? And we want to change that by providing them the agency of monitoring themselves, making sure that they can adhere to the medications, and then going back to the physicians and letting them know that they've been doing well or they've been doing bad. And that control is very essential for anyone who survived through a stroke.
And before we head back to the judges' room, is there anybody or anything you want to shout out or let the people know about what you're building here?
Well, a bunch of things, but I think I'll stick to the fact that with CaroRhythm, our journey has always been to improve stroke care, but we also want people to be aware of the fact that stroke can happen at any age. It's not just the old age. So if you are hypertensive, if you have high diabetes, that does mean that it kind of puts you at risk. So take the time out and make sure you take care of yourself by really relying on medical devices out there that help in improving that.
Thank you, Lokesh. My name is Leon. This is the On-Call Room, and we're headed back to the judges.
Hey, Lokesh. Welcome back.
Thank you so much for listening to our pitch, and we're really excited to have you on our journey. We're looking to raise $500,000, and happy to be here again.
So I have to say, unfortunately, you guys are still too early for us, but I'm even more compelled by what you guys are doing. So I would love to find some time after this event for us to get together to figure out how we can help out.
Thank you so much.
Well, we at SOSV love early. And so one of the things that I didn't get to share when I did the introduction is that the way that SOSV makes its investments is through these two programs. So IndieBio really focuses on biological or molecular or scientific companies, so think therapeutics, biomaterials, diagnostics, and which is the team that I sit on. However, we do have another team that looks at more hard tech, pure device companies, and the amount that you're raising is really kind of our sweet spot for where our first checks, I think, can really matter for companies at the earliest stages. So I would love to share your deck and any other information about your fundraise with that team and see if there's next steps.
That's perfect. Thank you.
Congratulations on the momentum. It's really incredible. And we spent a lot of time talking about the business case and the market, but also the impact that you're going to have with patients who, go home with the sword of Damocles hanging over their head. And so congratulations to you and the team. Do you have terms on the 500 raise?
Yes, we're looking to do safe with an 8 million cap.
Okay. And do you have anyone spoken for that?
We are in talks with two different ventures. Currently, it's still in second stage.
Great. Okay. And who owns the company?
We own the company. It's a spin out from NYU. So we do own we have an exclusive license with NYU to use the IP, and the IP is, we have a non-provisional IP under review.
Are you developing new IP as well?
We are also developing new IP at the company.
And that's a permanent exclusive from?
That's a permanent exclusive from NYU.
Okay, yeah. Great. Okay. Well, as for me, I would like to be helpful, maybe not on the funding side, trying to get you in front of some of our chairs who have a passion for stroke and an expertise in stroke, and other clinical leaders who are looking for opportunities to do research around stuff like this. So really impressed with the progress to date. I think down the line, if we could get some traction on the clinical side or the research side, then conversations around funding become way easier. Those aren't coupled, but they tend to be correlated. But either way, really impressed with the growth so far.
Thank you. That's very helpful.
So let's talk about what you're doing now. We've heard a little bit about your technology development. We've heard about where you're going from a fundraising perspective and a regulatory perspective. What's going on with the team right now? Can you tell us a little bit about Nisa, who wasn't here, unfortunately, and the rest of the team that you've gathered around of advisors, and how do you see that evolving over the next 18 months?
Right. Nisha and I, we both are actually working towards getting this product out there and talking to people. One of the things that we are doing is, and our advisors have helped, is to do outreach in community. We are actually doing a stroke survivor group in Syracuse next month. And we're really excited to go and talk to people out there, hear their stories, and get feedback from them on how we can help them improve. We're also reaching out to different healthcare institutes outside of New York City, trying to understand their challenges and how it's different, and also kind of understand how we can get across the payer landscape. And our last goal, one of the advisors that we are currently working with, is to work with the FDA side of things, mainly focused to apply for the FDA breakthrough program, which also helps us accelerate our de novo pathway.
And do you have that, by the way, that's all really good directions, all of those. Do you have the team that you need in place right now for the next 18 months, or do you need to grow that team in order to accomplish what you're trying to accomplish?
We definitely will grow the technical development team as well, and the clinical side. We have subcontractual agreements right now with our clinical collaborators that helps us do clinical studies and also helps us do the outreach. But definitely in the next 18 months, we will expand the team and try to do as much as we can.
And then one final question, I apologize. So one final question, when do you expect to get a little bit of clarity from the FDA? I know you need to do some clinical studies as well, but how are those two paths progressing?
So in terms of FDA, we are not required to do clinical studies all the way to Q-Sub. We have already had a Q-Sub meeting with them at the beginning of this year. We do hope to do another one, a follow-up, in terms of the technology we've developed, and talk to them in how we can improve. FDA is great in terms of giving feedback. They also have a new program that helps us communicate with payers directly, and that happens once a year. We are also looking forward there because that gives us opportunity to talk to Medicare Advantage plan holders and value-based care holders as well, and see how we can expand this further.
Excellent. We may be able to connect you to some of those too.
Thank you so much for your time. It was great meeting you all. I hope to connect with you.
Looking forward to it.
Congratulations.
Thank you.
That's it from the studio, but don't hang up just yet.
We'll be calling Lokesh back in just a few weeks.
A special thanks to the New York University Stern School of Business's Berkeley Center for Entrepreneurship team for making this production possible. Be sure to follow and subscribe so you don't miss future episodes of Capital Calling. Disclaimer, the Capital Calling podcast and any related media properties produced by Coas Collective are provided solely for informational and educational purposes. Nothing presented in this episode should be construed as an offer to sell or a solicitation of an offer to buy any securities, investments, or financial products. Coas Collective does not provide investment advice, and all opinions expressed are those of the host or guests at the time of recording.